All right, welcome. Today I'm going to be discussing the composition of blood and a few other important processes that involve blood. But first, let me just start out by describing um, exactly what makes up blood. When we put it in a centrifuge and we spin it, we end up having it separate out into these three distinct layers. The first one and largest is our plasma, and that plasma makes up about 55% of a person's blood volume. And it in itself is probably about 92% water. Uh, Plasma is known as a colloid, and the colloidal proteins in blood plasma are the albumin, globulins, and fibrinogens. Albumin is the most abundant protein in plasma, and it makes up about 60% of the total proteins in plasma. So it's a pretty big portion, pretty big deal. And albumin is largely responsible for having a constant osmotic pressure, or BCOP, within our capillaries in the cardiovascular system. Another really important protein is globulin, and it plays an important role in transporting substances within the blood. And it also is referred to as antibodies. And then the next important one is fibrinogen, which is an important clotting factor, and without it, our blood plasma is known as serum. And so, as you can see here, we have the separation of our plasma, which is made up of those three things I just mentioned: the plasma, globulin, and fibrinogen, and salts and some hormones. And then we have our buff layer here, and this is called the buffy coat or buffy layer, and this is where the white blood cells and platelets are separated out too. And then we have down here, we have the red blood cell, which is all of our red blood cells, and makes about 45% of our total volume. All right, next we're going to go over how these red blood cells are removed from the body. So red blood cells have about a lifespan of 120 days. So it's a pretty long time. But after that, they need to be removed, and the spleen comes into play here. The spleen is like a giant sponge or a giant filter. What happens is the blood cells will go through that normally. Because they're flexible, they're able to weave their way through. But as they get older, they become stiff and they get caught up in the spleen. And when this happens, that's when they start to break down by the spleen. And to kind of understand what's going on, we have to understand what's happening inside the red blood cell. Inside we have hemoglobin, and in this hemoglobin we have a few different variations. We've got alpha and beta and gamma. Now gamma will replace beta, and so you'll have alpha and gamma in babies, but in adults you'll have alpha and beta, and you'll have about 2 alpha, 2 beta, and each will have this group here called a heme group. And what happens is when this blood cell dies, this heme on the protein chain will go through oxygenase and will be turned into biliverdin, and then through biliverdin reductase will be turned into bilirubin. Now this bilirubin will then be transported through the body to the liver. When it reaches the liver, it'll be conjugated, which means that a bunch of glucose groups will be added to it, and then it'll come from the liver out into the bloodstream again, and it can go to a few different areas. It can go back into the intestines. Sorry, not to the bloodstream. It'll go into the intestines, and from the intestines it can go into the bloodstream. Or it'll go into the intestines and be excreted. In the intestines as well, we have this thing called urobilin, which can either be put into the bloodstream and put back into the liver, or it can go to the kidneys where it'll produce urobilin and be peed out. Another thing is that stercobilin is dark brown in the intestines, is made from urobilin. All right, something I forgot to mention is that the heme is broken down. When it's broken down into biliverdin, the iron ions bind to the blood protein and transferrin for transport. So that iron in the middle is taken out and transported. And then the unused heme groups can be recycled and used in hemopoiesis, or can be converted into bilirubin and used to make bile in the liver. The iron ions that we just got from the heme can also be transferred to the protein ferritin for storage in the liver. From there, it can go back and be made through hemopoiesis for the creation of erythrocytes in bone marrow. And in bone marrow, we have two different types. We have got the red bone marrow and the yellow. The red makes red blood cells and the yellow makes white blood cells. And they will go through a few different stages, from a stem cell down through erythroblast to a reticulocyte. And then the reticulocytes are going to be put into the bloodstream, where they will mature into erythrocytes. And then that's when we start removing old erythrocytes by bone marrow or in the liver or the spleen, like we talked about earlier. Okay, getting back to the liver and talking about bilirubin. And unconjugated bilirubin. When it's transferred to the liver, the bilirubin is taken up by the liver and conjugated with a gluconic acid, like I talked about a little bit before. And then the conjugated bilirubin is put back into the bile, and the bile goes into the intestines. And then from the intestines, the glucuronic acid, or the glucose groups, are removed by bacteria. And this is resulting in then the bilirubin being turned into the urobilinogen. From here, some of the urobilinogen is reabsorbed, while the other is put into the bloodstream again. And then from there, a portion of the urobilinogen will participate in the enterohepatic urobilinogen cycle. So we put back into the liver and start part of that cycle, while the remaining is transported by the blood to the kidneys, where the kidneys will convert it to yellow urobilinogen, and this is what yellow urobilin, and this is what gives urine its yellow color. Now, the stuff that remains in the intestines, the urobilinogen that remains in the intestines, will be converted into a brown pigment, and this is called stercobilin. An important thing to notice is that when you have an excess of buildup of bilirubin in the blood, you can get jaundice, and this is where the skin and whites of the eyes can take on a yellowish tinge. And this is not really good, because that means there's either a blockage in the bile duct, or if it's not quite jaundice, but there's, say, a bunch of high levels of unconjugated bilirubin, then there's something going on with the liver. And so these are kind of markers of possible issues going on with this system in your body. All right, next we're going to talk about hemostasis. And essentially this is just blood clotting in the body. So what happens is, when there is a opening up in the epithelium, we get these platelets that will come into contact with the tissue, the tissues there, and they will bind to those receptors. The von Willebrand factor, which is found in these basement membranes, or these epithelial cells, will bind to the platelets, and these platelets will then start to change and turn into this squiggly line. You can see here they'll turn from these platelets, and they'll come over here, and they'll bind, and they'll start looking like this snot looking thing. Now, inside these platelets, we have different granules. We've got dense granules, and then we've got alpha granules. And the dense granules have ADP and calcium, whereas the alpha granules are made up of van Willebrand factor, 5, 8, and PDGF. And then on these platelets, we also have these GP2B and then 3A, or also known as fibrinogen receptors. So to run through the whole process from the start, what will happen is the formation of a platelet plug starts with a vascular spasm, or what really is happening is it's constricting to reduce the blood flow to the area. Then what happens is that the von Willebrand factor will be secreted by these epithelial cells here, and they will bind to platelets, which are then activated, and they will change shape, and then the alpha granules in the platelets will release more von Willebrand factor, fibrinogen, and platelet-derived growth factor, which is the PDGF. Then the dense granules will release adenosine triphosphate, calcium, and serotonin. The thromboxane will be released from the membrane, and then different receptors like the VWF receptor and the fibrinogen receptors appear on the surface of activated platelets. So once those platelets are activated, then they will get the receptors to bind. Once this happens, ADP and thromboxane will then go over and activate more platelets to start their change. Then the fibrinogen will bind to fibrinogen receptors on activated platelets, and that is what's going on here. Is we got fibrinogen, which is this green stuff, will bind to other receptors, and they will link these platelets together to create this structure here. Then the clotting will begin. Clotting factors will lead to factor X, converting prothrombin to thrombin. And then thrombin will convert fibrinogen into fibrin to create a fibrous mesh to strengthen the plug. And this mesh is what will capture red and white blood cells. And so if you've seen photos, you can see these red blood cells and then this like yellowish, grayish, wispy stuff that's wrapping around all of it and catching these fibers and holding them together. And then actin and myosin in the platelets will contract to seal off the wound. And then so this is kind of the cycle that will happen when there's a perceived leak in the membrane. And it's a positive feedback system. So when the healthy cells release anticoagulants, it's a positive feedback system. But what happens is that the healthy cells around it, so these ones over here, will release anticoagulants to keep the platelet plug size limited to just the area that's damaged that can't release the platelet plugs. And then down here we can kind of see a little bit different the cascade that goes on. One of the important things is that there's some important drugs for the intrinsic pathway that we're going to talk about here in a minute, but it's Coumadin and warfarin. These are two pretty common drugs. I think warfarin is the generic name for Coumadin. But as we look down here into this cascade, this clotting cascade, we have two different sections. We've got the intrinsic pathway and we've got the extrinsic pathway. The intrinsic pathway is going to deal with factor 12, and this starts by binding to collagen, and it's going to do this cascade where it's going to go from 12 to 12A, then 11 is going to come in, let's go from 11 to 11A, then 9 is going to come in, that's going to go from 9 to 9A with a cofactor from 8, cofactor 8, I believe. And then that will go down to the common pathway, which both the intrinsic and extrinsic lead to, which is then 10, going and turning into 10A plus 5, cofactor 5. Then we've got 2, turning into 2A with thrombin. And then we've got 1 with fibrinogen, turning into 1A plus 12, or 13. 10, 11, 12, 13 with fibrin here. And then when you move over to the extrinsic pathway, you can see that when it hits the tissue factor, so this is caused by, this one is started by tissue factor, and this one is started by collagen in the from the release of collagen from the opening of that hole out of the blood veins or arteries or capillaries or wherever this leak is at, in the organs or externally on the skin. Anyways, for the extrinsic pathways, when we're talking about it binding with tissue factor, it'll go from 12 down to 12A, and then it'll go from 10 to 10A, and then it'll go back to the common pathway. So this one's a little bit shorter than the intrinsic, but they both lead back to the common pathway. And one thing that's important to know is that the intrinsic pathway and the extrinsic pathway are two separate ways for this clotting cascade to happen. And so depending on the type of drugs you give them, you want to be careful to know what is happening, because if you give them, say, heparin, but you have an extrinsic pathway going on, then their levels are going to be normal, and you're not going to understand why. Or say if their levels are low and you give them only heparin, and the extrinsic pathway is what's actually being affected, and nothing changes, it's because you're giving you're looking at the wrong one. The drug's affecting the wrong pathway. Two tests that we can use to see the levels are the PT test for the extrinsic, which is the prothrombin test, and it just really tells you how long it takes to clot relative to normal. And then you've got the PTT test, which is the same thing for in the intrinsic. Both these are kind of done in seconds and just tell you how long. So if you do the wrong test and you're trying to administer heparin and you do a PT test, you're not gonna see a change or difference that you're looking for, because you've blocked the wrong pathway and you're looking in the wrong area. So this next part was not really covered in class, but I'm going to talk about it briefly and just read from the textbook, and hopefully give a good discussion. So what happens is we have TPA, or tissue plasminogen activator, and that will cause the plasminogen to turn into plasmin, or plasmin. Sorry, they'll turn plasmin to turn into plasminogen, and then you have urokinase, which will turn plasminogen into plasmin, and then this will go to fibrin where it's cut. It'll cut it into fibrin degeneration products. So within several days of clot formation, an enzyme known as plasmin completely degrades fibrin, thus dissolving the clot through a process known as fibrinolysis. Plasmin is the active form of inactive plasma protein known as plasminogen. Plasminogen is synthesized and released by the liver and is converted to plasma by a number of different molecules, one of which is called TPA. Endothelial cells produce TPA. In the presence of fibrin, TPA greatly accelerates its enzyme function to convert plasminogen to plasmin, thus initiating the process of clot dissolution. It is interesting to note that by activating TPA, fibrin initiates its own degradation. TPA can be given to patients who are experiencing heart attacks or strokes caused by embolisms, which is floating blood clots. However, the treatment seems to be most effective if administered within 90 minutes of onset of symptoms. All right, and then here we've just got a quick little graph that I drew out, and this little what's this called? Chart. So as you can see, we've got the intrinsic and extrinsic pathway. So you can see we've got the test for intrinsic is PTT, extrinsic is PT. For the drugs you want to give them, so heparin for the intrinsic, and then Coumadin or warfarin for the extrinsic. The pathways, which we just discussed a little bit before, are laid out there. So this one goes from 12 down, where this other one will go from 7 down. But we'll need tissue factor. And then the activation is collagen for the intrinsic, and then factor 3, tissue factor, or thromboplastin for the extrinsic pathways. All right, thank you for listening to my video. Sorry about the jumping around and the coughing, feeling a little sick, and hope you have a good day. Bye.